Okay, friends, and we are back after a short summer break. No, COVID is not over, but not only do we have a very special guest today, but we also are live. Not really live for the day, but we're actually both in the same room. We are vaccinated. We are both physicians, but we are socially distant as well. So let's talk about our guest today. Now, I'd like to call her a rising star, but that's really just because I'm much older than her. She is a star within her own right, Dr. Michelle Henry. If you follow her on Instagram or you've turned on the TV or listened to Sirius Radio, you will know that she has really made her mark in the dermatologic world. She's trained at some of the best institutions, Baylor College of Medicine. She's been to Mount Sinai, where I'm an attending as well, quite a fine institution, and she's trained at Harvard. She is an expert in Mohs micrographic surgery, which means cutting out dangerous skin cancers, people. She is also an expert in aesthetic dermatology, cosmetic dermatology, and an expert in skin of color. Now, I hope that does you justice, Dr. Henry. And I think the subject of today, we're going to talk about a lot of things, but I want to talk about skin of color, what it is, what about treating it? You know, when I was a young star myself and a resident, there really weren't as many options as there are. It's such a hugely growing facet, and I think we're both really lucky to practice in New York City, which is a very diverse community. So we get to see a whole variety of types of patients. Well, let's first talk about what is skin of color and how we have to think about it in the dermatologic world. So welcome, and thank you for coming.
Thank you. I would love for you to introduce me everywhere. It was very gracious. I appreciate it. So what is skin of color? So in dermatology, we typically define skin of color based on its response to the sun. So we look at the Fitzpatrick photo skin types. However, it can be a little bit more complex than that. So a lot of what I do in my office is beyond just what I see and beyond just how one's skin responds to the sun. I also talk to them about their ethnicity, their heritage, because sometimes the skin can be a little sneaky. Yeah. And sometimes you can have skin that does not look of color that performs as if it is of color.
Exactly.
So a big part of my practice is making sure that we talk about ethnicity and heritage just as casually and comfortably as we talk about everything else, so we can really keep patients safe.
Let's talk about, because for the audience, which I always find biologically interesting, why is one skin darker ethnically than another's? Let's talk about skin cells. Let's hear about it.
So skin cells. So we talk about skin cells. We all know melanin. So melanin is what gives our skin its pigment. And there are melanocytes, which are the cells that create melanin. And no matter your skin type, your skin color, we all have the same number of melanocytes. But there are these organelles called melanosomes, which are kind of like melanin bags, are full of melanin. And skin of color, there's more melanin inside of those
Not
bags.
more melanocytes.
Not more melanocytes.
So you don't have more skin cells of color. You have more of these melanosomes.
Melanosomes, exactly. They're little packets of melanin. And they're packed full of melanin. And they're so packed full of melanin that I tell my patients that you just bump them and they leak it. And so this is why we see lots of hyperpigmentation in skin of color. And this is why in many ways skin of color can be quite sensitive. And it's because those melanosomes are so packed full of melanin.
I always find it so interesting if you look under a microscope, and we know melanocytes and all these things. It's amazing to me how many beautiful shades of skin can be created. I mean, it really is amazing. If you think about the ethnicities of people all over the world, it's not just black or white. You know what I mean? There's so many shades in between, and you've been in practice many years. I've been in practice too many years to mention. What's really amazing is the different responses. The different responses. And it really makes it quite complicated as a dermatologist, because we really have to treat people based on this. And, you know, there are pros and cons. Let's talk about the pros and cons of aging. I tell people there's no perfect skin type, but there are things that we have to be aware of, and there are certain skin ethnicities that have certain susceptibilities. So let's talk about that a little bit.
Exactly. So I always say, we hear these phrases like black don't crack or Asian don't raisin.
I haven't heard that one. Asian don't raisin. I take that one. Okay.
And it's not that that skin of color doesn't age, it just ages differently. So I tell my patients is that, we're all aging. And so I often refer to like my white patients as my wrinklers and my shrinkers, and my patients of color as my sinkers and my saggers. And so we're all kind of aging, we're just aging differently. So you just have to have a different eye.
Sinkers and saggers. These are good. Everyone has, I call them PFRANKMD isms. You got to call them the Henry isms or something, because it's true.
Yeah.
People have to understand these things.
Exactly.
Yeah, and actually, in Asian skin types, I find that their skin holds up very, very well to a certain age, and then there's almost like a rapid sense of aging that they have.
Yeah.
Whereas, I think certain like men have thicker, they have more collagen in their skin. I think African American type 5 type skins, there's a greater thickness in the skin, which is why when it loses its elasticity, it can get heavier. But I think you and I could both agree that a lot of darker skin tones don't think they have to wear sunscreen. Is that correct?
Yeah, that is fake news. I tell all of my patients everyone must wear sunscreen. For many reasons. A, we see skin cancer in skin of color.
Yeah. Do you, as a skin? Because you're not just a cosmetic dermatologist. You cut out skin cancers. You're like a real doctor. You do serious stuff here, and you're seeing this.
Yeah, we do, and of course you don't see it as often. But when we do see it, outcomes are worse because there's often a lower index of suspicion. And I always say, my uncle is skin type 6, so darker skin than me even, had a basal cell in his eyelid this year. And I thought, how am I a Mohs surgeon?
So you'd say you're a skin type 5?
I think I'm a 5. I'm a dark 5.
You're a dark 5. So 1 is like pasty white guys. Okay, it's like Lindsay Lohan style.
Yes.
Okay, and 6 is very dark.
Like Alec Weck, the model Alec Weck.
Yeah.
Alec Weck is or Kevin Hart, I think is a.
And by the way, just so if you don't think people skin of color get skin cancer, Bob Marley died of melanoma.
Exactly.
Famous. I always give that, people like, what? I gotta wear Bob Marley died of skin cancer. So it's a serious thing, and starting young with sun protection. Now, also they get different types of cancers too, right? Skin of color.
Yeah. So you get all sorts of cancers in skin of color. So you get melanoma. Yeah. You see, you can see basal cell. They're usually pigmented. Yeah. You can see squamous cell, which is a little bit more common in skin of color. You can see another kind of, it's a blood cancer that manifests in the skin. It's called mycosis fungoides. So we can see MF.
I've heard of that.
A little bit. We can see DFSP. So, so lots of skin cancers. And that's why I always say that a lot of my patients of color believe that they don't have to have an annual skin check, and it's beyond just the skin cancers that we see with UV light. There are other cancers that we pick up as dermatologists too.
I always say the best way to scare people into sunscreen, though, is not the fear of cancer. I'm 100%. You have a very mixed group of patients: medical, skin cancer, oncology, cosmetic. I just scare them by telling them it's going to make them look older, and that's the way to do it, because a lot of the things that we do to make your skin healthier, like resurfacing, can decrease your risk of skin cancer as well. But patients with darker skin tones, they don't realize. I say, look at your parents. Their skin is probably darkening as they get older. And, hyperpigmentation is probably the biggest sign of sun damage in skin of color. Exactly.
And it's also about having that different eye. And so, like I tell my patients of color, you're aging just differently. And one of those signs of aging is getting that dyspigmentation, that hyperpigmentation, that uneven skin tone, and sunscreen is the answer.
Yeah. And it's actually not just the darkness of the skin from certain areas of the world, like the Middle East or Pakistan, India. They tend to get a certain distribution of hyperpigmentation around the eyes, the forehead, right? And it really is from where they are in the world, not just the darkness of their skin. And I always kind of try and theorize why that is, but it's very stereotypical.
It is, and it's funny because we don't see it a lot. They call them pigmentary demarcation lines in India. We don't see it in our textbooks, but it's in Indian textbooks. It's always there. I actually have them, and I treat mine, and I fade them already. My mom has them, and so you're absolutely right.
And the later it happens, the harder it is to treat. And this is true with everything. I always talk about cleaning up your room before it gets too dirty, and this is particularly true of things like hyperpigmentation. So we're on the topic, so I think we've assessed that people with darker skin tones, that's like their number one concern. Dark circles around the eyes, forehead. Also, anytime they have inflammation of their skin, they're getting dark spots, right? Acne, they cut themselves.
Exactly, mosquito bite.
Mosquito bites. And the earlier you intervene, I always say, the longer it stays when it comes to hyperpigmentation.
That's a good one.
So, you like that? That's
like that.
The longer it stays. You know what I got that? I got that one from being in the hospital during my internship. I did my internship at Columbia, and that was like the thing, like, get out of the hospital. If you're free, don't hang around and talk to the other residents who are on call. Like, the longer you stay, someone's going to grab you, and the longer you're going to stay. So it's true like that, And I think a lot of these people don't realize that a lot of the pigmentation we grew up with is not inborn. As you get older, like just the head will get darker than areas of the body.
Yeah.
And people just think it's their natural color. They'll pull up their sleeves sometimes, and the chronic photo damage causes a permanent, this happens in Caucasian people as well. So how do we treat all this? This is the question. Because when I got out of residency, I was the most cutting edge laser surgeon around. I had 3 lasers. I had a light shear diode for hair removal. I had a MedLight Q-switch Nd:YAG. It was a tattoo laser. This is early days. And I had a V-beam, which is for blood vessels. Now, we could talk endlessly about how many devices are out there. But let's talk about lasers for pigment. Hit me with what you got.
Yeah, and lasers for pigment, especially in skin of color, it's tough.
Why is that? Let's tell the audience why that is.
It's tough because you want to target the pigment. So when you're using a laser, the laser has to differentiate between the target and normal skin.
Contrast.
It has to have contrast, exactly. And if it gets confused, that's when you have negative outcomes. You get burns. And so if you have dark skin and you have a dark spot, it's tricky. And you also want the laser to be able to bypass the melanin on the surface and
the
get
good stuff.
Exactly. Leave the good stuff and get to the bad stuff. And so, a lot of the lasers we look for are those 1064 lasers because
they go deeper.
They go deep, slightly lower affinity for melanin on the surface. So variations of that. And then lasers that move really quickly through the skin so they don't build up heat.
And pain also, darker skin types. Right? If you have more, another ism of mine, black top absorbs the heat of the sun more than a grass top. And that's what makes lasers susceptible to burning. People don't understand when I tell them they can't do CO2 laser resurfacing if they are, anything more than type 3 skin. You could in certain circumstances, but it definitely puts people at higher risk to do resurfacing of certain kinds. And what people don't realize, that's pigmentation in the skin is very three-dimensional. We have the epidermis, right? It's the top layer, and then you have the dermis, which is deeper. And people with skin of color tend to get more of a wider distribution of depth, right? So it's about how deep can you go and how deep can you go safely.
Exactly.
Now, since Dr. Henry has been a physician, there have been some great advancements. I don't know if they're all due to her, but there have been some great advancements. What are some of the names of the devices that you like using in your office? Well, first of all, tell me what percentage would you say of your patients are skin of color? Because clearly you're an expert in it. People are probably going to, but also, I think a lot of practitioners in New York have skin of color patients.
Yeah, that's the beauty of New York. So many people encounter skin of color, so they learn it, and there are many. But I see a lot of skin of color patients. I would say from my aesthetic patients, 50%, maybe a little bit more of my aesthetic patients, and maybe about 60% of my medical patients.
Okay.
So we're pretty evenly split with aesthetics, but I see a lot of skin of color.
And medical, medically too. It's not just cosmetically. There are differences.
Yeah. So
there's certain different susceptibilities, different issues with hair loss, things of that nature. What are some of the more common medical things that you think you see?
Yeah, so I see the bread and butter things, acne, but I also see a lot of hair. So a lot of hair loss. There's an epidemic of hair loss, and especially in the African American community.
Why do you think that is?
For many reasons. I think CCCA. We see a lot of CCCA. We know that there's a genetic component, but then
tell the audience what
CCCA.
CCCA.
CCCA. It's a type of central centrifugal cicatricial alopecia.
Say that 10 times.
I could not. I'm lucky I got it once. But it's a type of hair loss where so you start to see it in the center of the scalp. It spreads outwards. It's scarring.
It's scarring. No bueno.
No bueno. It's painful. It's itchy. And because there's a strong hereditary component, a lot of my patients come in really late because they're like, oh, my mom has it. It's hereditary. There's nothing I can do. And it's triggered by a lot of the unique styling practices of
I was going to say unique styling practices could cause it also.
Exactly.
Yeah. And of course, getting people to stop those habits, grooming habits are really difficult.
And it's hard because by the time they come in, they've lost, 25% of their hair. And I can't tell them now you have to stop using what you're using to conceal the hair loss.
Yeah.
And so, it's tough. It's
hair loss in women in general is a very difficult thing because they come in with a preconceived notion that it shouldn't be happening to them.
Exactly.
People just say it's just guys. But it really is epidemic. I think even now in COVID, stress-related stuff. I myself, when I had COVID, had a telogen effluvium where you get this shedding. Yeah. I've been working very hard for decades to hold on with multiple surgical procedures. Thank you. transplants are holding. But no, I mean, it's a very common problem amongst women, and it's very distressing, right?
Yeah.
So let's get back to lasers. You mentioned 1064 types of things. So let's talk about that. There are a lot of different brands out there. What is it about these 1064 lasers that may be better for darker skin tones?
So much better because, again, it's bypassing that superficial melanin, and so it's less likely to cause a burn. It's going a little bit deeper, and it has a slightly lower affinity for melanin than, let's say, like a 532 or something that might be more likely to burn.
The longer the wavelength, the deeper it goes. That's the way lasers work, kids.
Melanin,
The longer the wavelength, the deeper it goes.
Yeah. So that is my go-to for many treatments, and we've become very creative with that wavelength so that we can do more things in skin of color. So I use, I have a Cutera, so I use that, the Zeo. I use the Aerolase, which is great. I have a Picashore, which also has a 1064 handpiece.
Oh, it does? Okay.
So I use that. And then, I do a lot of the other things. So not 1064s, but radio frequency. I think we were just talking about that.
Yeah, radio frequency. Lasers really focus light and are very sensitive to pigment. So there are so many other technologies that have come about the last several years. Ultrasound technology, radio frequency technology, microneedling. Microneedling is huge right now. We were just talking about that before we started. Unfortunately, a lot of these machines can be sold to the public and to the physicians like, this can't cause hyperpigmentation. Because for every treatment out there that could help hyperpigmentation, it could also
cause it. Exactly.
It could also cause it.
Exacerbate.
And I think that's really the skill of the provider in choosing the right candidate and in doing it the right way. And what's most difficult sometimes is the population of skin of color may have a tendency to not be around the best of providers. In the med spa culture, they'll get oversold technologies, and they'll deal with the most common complication, which is actually getting hyperpigmentation from treatments.
Exactly. Absolutely right. And I think there's a lot of miseducation and a lack of understanding, a lack of transparency. So, I think a lot of patients of color, like medical aesthetics, it's just becoming like normal. It's becoming normalized in the community. Like social media is
non-medical, like a form of grooming.
Exactly. So it's like we're demystifying it with social media and conversations like this. But there's a lot of misinformation, so they don't know where to go. And they don't go into places like you said and getting burns.
Where there's just and again, there's nothing wrong with extenders. I've always talked about this. I have many extenders that work for me, but you need to have a place where there are experienced providers with hierarchy of oversight from true experts in the field.
Exactly.
Not everybody has to go to the famous Dr. Michelle Henry or even Dr. Frank, but everyone needs to do their research. And unfortunately, patients of skin of color are at the highest risk. And in a place like New York State, you have to be a healthcare professional to use a laser, except hair removal. But hair removal can be the highest risk procedure.
Absolutely. I had a patient who actually ended up at the Cornell burn unit because he had his hair removal at a spa. They told him, "Oh, you're hurting because you're a guy. Men are wimpy." And he went home and sheets of skin. Yeah.
I always tell patients, and the first thing when I teach my extenders, my PAs, my nurses about doing hair removal and things like that, the number one thing to watch out for is pain. I don't care if patients are sissy. Yes, there's a subjective component, but if you're doing any laser technology or getting anything out there, people, and it's just too uncomfortable. It's not uncomfortable. It's painful. You stop.
Exactly.
Because sometimes it's not the patient, it's the machine.
Yeah.
And most often it's the provider not having the proper judgment.
Exactly.
So these are like important things that consumers out there have to know. And I take very seriously as a provider. Sometimes even it's on a low setting. I stop the treatment. I make sure the setting's right. Are the windows dirty?
Exactly.
In med spa culture, you may not get this.
Yeah.
Now, you combine treatments too.
Absolutely.
Right?
Yeah.
Tell me how you may combine some of these kind of wavelengths and things like that to get the maximum result.
So I think something that I often do, I'll combine, something like simple as the Aerolase with a chemical peel.
Aerolase is like really for skin of color. It's like my favorite device. I don't get paid by them. I really don't. It's a long pulsed laser that really, I don't know, there's something about it that works quite well. It's very safe. Takes multiple treatments.
It does. So it takes multiple treatments, and I even do the laser toning, which is really popular in Korea to help with pigment.
Of course.
Many treatments, low energy. I love it for acne.
Yeah,
it's
it does work great for acne.
But I'll combine that with chemical peels sometimes. I'll do the same sometimes if I'm even doing a little bit of radiofrequency microneedling. I will combine that with I'll do a little bit of aerolase, and I will even take my Pico on top of it sometimes if I have more discrete areas.
The art of what we do is in combination. It really is. And having enough experience to understand what the balance is, knowing the feedback from the patient, from the skin, and learning about each individual, because, you could have 10 people, they could be all identical twins, and there's a different reaction to things.
Exactly.
And that's the fun part to me. I often use one of my go-tos for skin of color with melasma and post-inflammatory pigmentation after whatever trauma is using something like the Aerolase or a Picogenesis. I have the Enlighten, the Cutera Picogenesis. And I'll do like a light thulium.
Clear and brilliant, yeah.
A light thulium, because all pigment is not created equal, right? A sunspot is mostly epidermal, top layer. A dark-skinned patient who has a burn that leaves a dark mark is probably mostly dermal deep pigment, right?
Yeah.
And there are tricks, like we shine blue lights on people. Do you have I don't have a blue light in my office. Do you have a blue light?
I don't have a blue light, I have a black light.
A black light.
Yeah.
A black light. That's what I meant. These are those things that make your teeth look white and the tonic glow when you're at a party in high school. No, I meant the black light. I don't know. I have to see if I have one of those. But, you acquire enough experience over years, and you could look at the skin, and you could pretty much tell the depth of that pigment. And when you find that depth, then you choose your device for all that.
Exactly.
Let's talk a little bit about hypopigment, which is like...
That's tricky.
It's not
tough.
a good word.
Yeah.
Hypopigmentation is loss of pigment, white spots. People always think of vitiligo, right?
Exactly. Loss of pigmentation, when it comes from a laser, that is probably the worst outcome.
Yeah.
Hyperpigmentation is so much easier to treat. There are some tricks that we have with hypopigmentation.
Tell me, what are your tricks?
So my tricks. I will combine a little bit of sometimes microneedling with Latisse and.
Latisse? Yeah. Does that help?
I have had some success. I will mix the Latisse with tretinoin.
Yeah.
So I'll do Latisse, tretinoin, and either Fraxel. I'll have them come in for Fraxel
Thulium,
treatments.
right? The Thulium.
Yeah, the 1927.
The 1927.
Exactly.
Guttate hypomelanosis, things like that.
Exactly.
I've had good results with that.
Yeah, so I'll use it for that. That's really the only thing that I've known. Some people say they'll use just like the pen microneedling and Latisse.
Yeah.
I've never done that.
So what do? You microneedle over it to create the wounds, the micro wounds, and then you rub Latisse over it.
Yeah.
And how often would you do that?
That's not something I do, but they do it maybe monthly.
Yeah, really?
If I have a patient do it at home. So sometimes if I have a patient that's very cost sensitive and cannot do microneedling, because in my office I don't do the pen microneedling because I don't think the results last very long. So I only do the microneedling RF. But I will have them do the derma roller at home. And I've had some improvement with the derma roller and Latisse and tretinoin for patients that are really cost sensitive.
Yeah.
It was a post-tattoo removal, and they had somewhere else, and they had hypopigmentation.
Yeah.
We got some improvement.
Yeah.
So it is about just creating that microtrauma, and it's kind of like what we do with laser-assisted drug delivery, creating channels
That's right.
so the medicine can penetrate.
That's right.
And so I've seen some results with that.
I forget what it was. There was some old school irritant.
Yeah.
That, because again, if you irritate the skin and skin of color, you can get, you stimulate melanocytes. It's just a difficult condition. A few years ago, I started working with a cosmetic tattoo artist, and Christopher Drummond, who most of my audience knows very, very well, who's full-time here. He started out microblading, and we started doing different things with people with localized vitiligo, which is disease where you lose them, hypopigmented scars from facelift, breast lift surgery, all this type of stuff. And it really is amazing. And when I see a hypopigmented scar, that's my go-to. Now, if you have to be cautious with tanning around it and stuff like that, and maybe every few years you have to redo it, but it really makes such a big difference. Even people with like those guttate hypomelanosis, for the audience, is like when you have those little white people get it too, right? Yeah. These little white spots down the leg. Yeah. And you could do little micropigmentation. It's really quite amazing.
Come get mine done.
Yeah, I mean, we all have it. I'm a little tan right now. It's hypopigmentation, I think, like hair loss, is one of the uncharted holy grails of cosmetic dermatology. Yeah. And I'll tell you, for the last 25 years, which I've been in dermatology, we've been 5 to 10 years away from the cure for baldness and hypopigmentation. So whenever someone tells you we are 5 to 10 years away from the cure to cancer or cure, you know what that means? It means they don't know shit.
It means it's not in your lifetime.
Yeah, it's not happening. Okay, I'm still waiting for that cure, but it's really difficult. And I think like Winnie Harlow, the model who has vitiligo, it's really a good example of seeing people that are shedding light that. You know, there are some serious diseases of this, and we'll hopefully work on finding ways to improve it. Let's talk briefly about face versus body, because skin on the body is a different animal. I've always found, whether I'm doing a laser procedure or someone gets a mosquito bite, 4 days of healing on the face could literally be 4 to 6 weeks on the body. And for skin of color, that could be a problem if you have a wound.
Absolutely.
There. So tell me about that.
Yeah, same thing I tell my patients. I say we have all the cruddy oxygen there. You know, it's just slow wound healing. You know, our skin cells don't turn over as rapidly. And so I'm very, very, very careful. So even with anything, even as simple as a peel, you know, once I'm going beyond the neck, I lower my concentration.
You can't use the same laser, like even in Caucasian people, I'm really not using like the aggressive CO2 lasers on the body. You really have to, there are people, they're like, oh, I did this on my face and then I went to some such and such med spa, whatever, pediatrician that bought a laser and they did it on my leg and I have burns.
Yeah, exactly.
Right.
And so you have to be very, very careful on the body. And so, I tell my patients, I go low and slow, or long and slow. Let me say that again. I tell my patients, I go low and long.
Low and long.
Low and long.
All right.
So low energies and longer treatments.
And longer treatments, right?
Yeah.
And maybe more treatment.
multiple treatments. That's what I mean.
Yeah.
It sounds better when I'm saying it in the office.
Yeah.
But lower energy level, but multiple treatments. So it's a longer treatment time period. But that's the best way to approach it because you have to be really careful.
Do you think it's really due to the blood supply? I mean, what is it, do you think, that from a biology standpoint, I always say, well, the best blood supply is to the head and the neck. No one really knows.
We don't really know.
We make things up.
Yeah, and we're not like mildly hypoxic on our or something, So maybe that's likely not it. But I think it may also be a part of the fact that we do pull more blood there. We're going to have more blood byproducts and cruddy,
That's
so it's just sluggish when we're comparing the legs to, let's say, the face. So I think it may play a role, even though it's not like frankly hypoxic down there.
I usually like to give people a rule because, when people are coming in for resurfacing of any skin type, once they do the face, they want to do the chest, the arms, the hands, the legs, the shins, everything. So I really like to, I generally, and this is for the audience out there, generally when you're doing any type of resurfacing device, there's no laser that's going to heal you faster than another, really. It has to do with the skin's, the biological turnover. And the face, generally, in anywhere from 4 to 7 days it takes. Once you get to the arms and hands, I would say it's more like good 10 to 14 days. And then the legs could be a month.
So sometimes I will do, and I think, of course I don't have studies to back this, but I'll say anecdotally, at least in my patient population, I'll do a little bit of PRP on top of it. And I find that might speed up the
Do you really think that?
I think so.
And listen, this is valuable to hear because I usually tell people, other than for hair loss, I think PRP is a waste of time. I just haven't seen it.
Yeah, and it's not that I think it's. I'm not using it to augment the results. I think that it may reduce the inflammation. I think it might speed the wound healing just a little bit.
And that makes sense.
Yeah, so I'm not doing it because I think it, for PRP, I'm the same as you. People come in wanting in their tear troughs. I don't think it works in that way. I don't think the laser lift works. I'll do it like on top of a laser if someone wants it. And
it could help healing, hypothetically.
Yeah, it helps with healing.
There is science behind the wound healing. There's science in joints where there's inflammation. But when people are doing it like the vampire, they're like injecting into the face like a filler. It just doesn't work. I think it takes a very experienced person to understand and share with patients that whether it's the part of the body or the darkness of their skin tone, there has to be a lot of patience involved, right? Because darker skin tones, definitely, you cannot conquer Rome in a day.
Absolutely. Like I tell my patients, one of my first lines, I hope this one works, is that this is an exercise in patience.
It's an exercise
everything
in
that we're doing in exercise.
Yeah,
in
you have to kick sand off the mountain, not throw dynamite in it. That's my line.
Oh, I like it.
Because I want to throw dynamite. I want to do it for them. We like wow stuff.
Yeah.
You know what I mean? And it takes judgment, and it takes hand holding, and it takes patience. And I think as a provider, there really is an art to feeling out somebody, because you have to take into consideration more than just the color of their skin, the size of their wallet, their patience, their level of expectation. There are certain things we can accomplish and not, right?
Exactly.
And I think you only get that through practice.
Yeah, and the confidence to say it. I know when I first started, I'm afraid to say what we can't do, because you feel like it's a reflection on your expertise, but part of your expertise is knowing what we can't do, right?
Absolutely.
And so I think it really reflects the maturity of your practice and your expertise when you can say this is not possible.
It takes time.
Yeah.
Tell me a little bit about skincare.
Yes.
Is there certain things about skincare that you recommend differently for your skin of color patients than your fair skin patients?
There were maybe
Other
some
than sunscreen.
Yeah, maybe there are a few things. Per the literature and skin of color, maybe there are slightly fewer ceramides, and so skin of color patients may not tolerate benzoyl peroxide as much. Do I use it in my practice? Absolutely, but I might be a little bit more careful when using higher concentrations of benzoyl peroxide in skin of color. Beyond that, a lot of it is similar.
You may use products that target pigment more.
Yeah,
right?
I may use. I'm always going to use something that targets pigment. So I always have some baseline product, because I tell them we want to treat and prevent.
Yeah.
So anyone of color is going to be susceptible. So almost every patient of color, whether it's a cosmeceutical or I'm using, with acne, I'm always using azelaic acid to help combat that. Or they're always going to have some sort of vitamin C or niacinamide or some sort of serum or treatment that's going to kind of preventatively work against hyperpigmentation. So that's a difference as well. And then things like you said, we have to go slowly. So a lot of my patients of color may have this idea that their skin is not as sensitive because it doesn't show redness as readily. But oftentimes it's exquisitely sensitive, and things like excessively using their retinoid will give hyperpigmentation.
Oh, absolutely.
So that's a big conversation.
I guess things that can make you better could also make you worse.
Exactly.
Scrubbing or things of that nature. They think their skin is dry and it's really irritated.
Exactly. So there are lots of conversations about, I always say, like, respect the melanin, stay on its side.
Respect the melanin. That's your
go
takeaway,
slowly.
kids.
Respect the melanin.
The melanin.
Go
Do you
slowly.
ever use, for some reason I find in my skin of color patients, transexamic acid orally.
Yeah.
Oh, wow.
It's a wow for so many reasons. So I use it for melasma. I use it for all sorts of things. I've used it for EDP.
Yeah.
I've used it for really long-standing hyperpigmentation, and I've been wowed by it often. So it's something that I do use a lot.
Tell the history. The history of it. Let's tell the audience what the history of it.
So tranexamic acid was a medication initially given for women with heavy periods, because it slows down the bleeding. But there's in the pathway. Let me get my words.
I don't know the pathway.
The arachidonic acid pathway. Okay. Let me work it out. Give me a second to work through my words, because I don't want to say it incorrectly. So in one of the inflammatory pathways, one of the byproducts stimulates pigment. Yeah. And because it stops that, that's how
she's teaching me this now, because I knew it affected the pigment in some way. I didn't know that they actually knew the exact pathway.
Yeah, they have the pathway. I have it on my phone somewhere because I talk about it, but right now I'm not getting it completely. But it's in one of our inflammatory pathways.
And a lower dose than what is used for heavy periods, right?
Exactly. And like plastic surgeons will give massive doses when they're doing facelifts to prevent bruising. And so we were so afraid of it, but when I talk to our surgical colleagues, they're like, we use doses far higher than that. Maybe not long term. But they use far higher doses.
It's pretty safe.
It's a safe medication.
Do you use it? And one of the contraindications they say is any type of hormone replacement, because one of the risks can be some sort of blood clotting stroke if you're a heavy smoker, if you're on birth control pill.
Exactly. So I don't give it to people who have any clotting history. I don't give it to smokers. I don't give it to women who are on oral contraceptives, especially when they're older than 35.
Do you really think that's an impact? I think eventually we're going to be able to use it on women with birth control pill. I think the dose is low. It's not a clot former. It's a clot stabilizer.
This is very true. And I think that medically I understand that, but I think that
who's going to take
right? Yeah, right now it's like, well, I think you're absolutely right. Once we're more comfortable with it, we have more data, and if a patient of ours was to get a clot, we have data from thousands of patients. We feel more comfortable.
It's like the whole days of you can't do any laser while on Accutane or for
now
like a
we're
year
like-
afterwards. I do lasers on Accutane patients all the time.
Yeah.
I'm not doing CO2 laser on
Yeah.
them. And I'm certainly doing heavier resurfacing lasers on them like 1 month after they're done.
Yeah.
I use a lot of Accutane in my skin of color patients because I don't want them to get brown spots.
Exactly.
I see a beautiful teenage girl with nice, beautiful dark skin, and I see like 5 brown spots. I'm like, you're going on Accutane.
Yeah,
you know?
you're absolutely right. That's something that I like to say as well. And it's not that I'm not aggressive in my lighter skin patients or my white patients, but with darker skin patients, you know that pigment's going to last forever and it can be disfiguring. And so I am even more comfortable being a little bit more aggressive with something like Accutane.
Yeah. All right, so now we get to the part of the podcast where we're coming to an end. Don't worry, I'm not going to keep you here all night. But now we get to hear, like all my guests, I want to hear some of your secrets.
Yes.
I want to hear some of your skin of color. Not only do you treat skin of color, you yourself are skin of color. Are there certain things personally that you found work great for you based on your skin type?
Yeah, so one thing that works great for me, and everyone gets it.
I want unpaid recommendations.
Unpaid,
Because by the way,
unpaid.
she talks for everybody, guys, okay?
But that makes me unbiased because I will upset anytime I talk about something. I'm upsetting someone else. If I'm talking about it, I like it because I kind of work a lot. But I will say, for me, something naughty that I do that we tell people not to do is I use my retinoid morning and night.
Oh, really?
Because I'm hyper acne prone and I was on Accutane prior. And it's great for my hyperpigmentation. So I do it morning and night.
What kind of retinoid do you use?
I use, and I don't work with them, I use L-Treno. So it's the tretinoin. And, I love it. But I use all of them. I use that. I'll use Tazarac. I'll use whatever sample.
Right, there's no best product.
Yeah.
It's like everyone's different. There's always, you take an expert recommendation, you have to try things, right?
Exactly. So I mean, I use whatever samples I may have at that time. But right now I'm using L-Treno. I also like Eraslo.
You
So
have a full closet of options,
do.
unlike most people. So that's right. That's right.
But I use that. I do peels maybe 2 to 3 times a year.
Okay.
Lots of moisturizer. I use,
You use the sunscreen.
lots of sunscreen. Yeah. So I use sunscreen religiously.
Yeah.
I even, except for this vacation, I had a little hiccup, but typically I even set my alarm clock to remind me every 2 hours, which is obsessive.
Are you someone that, do you have is it a big regimen or you just like keep it pretty focused? You switch up and
I
stuff.
switch up a lot. So
You do.
I would say I have an intuitive skincare approach.
Yeah.
So I just
Well, you are a dermatologist. If you're not going to be intuitive, I don't know what it is. Mine is like using Dove soap in the shower.
Really?
I don't use anything.
Are you kidding?
I'm not good. I just Fraxel my face and do some old therapy. I'm more of a go to the dentist and get the hard. I brush my teeth. But, I'm a minimalist, as are most men.
Yeah.
I just, in a world where I do a lot of procedure stuff, I believe in good skincare, but what I don't believe in is unnecessary skincare. And you as a professional, you could find out the essentials for you. And I think, unfortunately, the overwhelming majority of people out there who are crazy about skincare are crazy about skincare.
You're right.
It's
and
a problem.
you're right. Do I believe you need 14 steps? Absolutely not.
Yeah.
Do I believe that some people enjoy that as their self-care ritual? Yeah.
Yeah. And if you enjoy it and it serves you.
Yeah, but it's not for your skin. You're doing it for your mind, right? Because you enjoy that.
Yeah.
You enjoy playing around with it. That's
right.
absolutely fine. That's what I tell my patients. But for me, I'm kind of a 2 or 3 step girl. So my retinoid is my mainstay. I use a moisturizer. And then, I'll use a vitamin C from time to time when I'm
And you're hitting, Dr. Henry's hitting the greatest hits here, guys. Retinoids, only FDA-proven anti-aging, vitamin C, proven antioxidant, sunscreen, moisturizer. Really, everything else is just trying to achieve that.
Exactly. You're right. Everything else.
Those are the gold standards, and they have and will always be. It's not often that groundbreaking things come out. There's just a lot of substitutes.
Exactly. The more elegant formulation. So you're kind of playing around with what feels best. But you're right. Those are the gold standards. I don't think there's anything other than sunscreen more transformative for the skin than retinoid. So I feel like you must, if you could tolerate it, you must have it. Those are my mainstay treatments.
What about out of the office? What is your pro-aging thing that makes you feel like your skin, your body, and your mind glow? Is there something that you do, an exercise, a nutritional type thing, a vacation, something, walk with your dog? Tell me what serves you.
I will tell you what serves me. I have as many of us do, have a very tight mind-body interface. And so the second I'm stressed, I break out. The minute I'm not sleeping, I look awful. So I have to sleep well. I have to do things to maintain like a healthy mental state. So I meditate.
Yeah.
You
What
know,
kind of meditation do you do?
I do Transcendental Meditation.
Oh my God, give me 5.
Yay!
Twice a
Oh,
day.
really?
I had Bob Roth from
Oh,
David
seriously?
Lynch. He was on the podcast.
Oh, I love it.
Oh yeah, I'm a big TM guy.
Yeah, I'm a huge fan. I try to do TM when I'm being lazy because it's an effort. I will do kind of guided meditation. I'll do some of the apps. I'll do Calm. But I do think it is better and more impactful when I'm doing proper TM.
How many years have you been doing?
I probably did the training 4 years ago.
Oh, to me, I mean, it's life changing, right? To me, it was one of the biggest transformative things. I actually got it as a present for my wife. I would do it with her, quote unquote. And I just like the hypnotist, just like I was out.
And no, it's huge. And when you do it, yeah, you're right. When you do it, it changes you.
That's what I've always attributed so much of the mind-body connection to, and I think it's such an important thing. And I know, like you, from my research from you, and I think most best cosmetic surgeons now, you really have to take a holistic approach where you get to know your patients a little bit, because you can't inject smiles into people's faces. You can't laser away misery.
Exactly.
You and I are the icing on the cake. And this is what I always say. And your best results come from, you can't tell people what to do, but maybe helping guide them. They look to us. We're physicians. We're experts.
Yeah.
Sometimes they look up to us a little bit more than they should, but we have to provide that kind of holistic, broad spectrum approach to help them with their life, whether it's their diet, their exercise, and resources.
Yeah. Like I tell my patients, I am a happiness and wellness doula. So I'm going to get you there. And I kind of find like I have the tools to get you there. And if it's aesthetics, if it's talking to you and smiling at you, if it's skincare, if it's whatever it is, I just want to bring you to the other side.
I couldn't think of a better way to close this out with TM. I mean, Dr. Henry and I have both worked a very long day. It is in the evening because we're too busy during the day to film this. So we're not going to keep her forever because we both haven't eaten. But I mean, truthfully, TM is the secret. And I think we learned a lot about skin of color today. And you have reinforced to me why so many people listen to you, Michelle.
Oh, thank you.
And I want you to tell the audience how they could hear more of you.
Yes, and thank you for having me. This was amazing in your amazing office.
Thank you.
This is just goals, I must say. But you can find me at Dr. Michelle Henry on Instagram. And my practice website is Skin and Aesthetic Surgery of Manhattan. So you can find me there. And I'll see you there.
And that's it. And just turn on the television or Sirius Radio or anything, or open up a magazine, guys, because she's everywhere. Keep an eye out for this one, not just skin of color, but for all things, including things like skin cancer, because it is all related. It's not just looking good, it's feeling good, keeping your skin healthy. And thank you all for joining the Pro Aging Podcast. We will see you soon.